All right, guys, so here is your video for the antibiotics one. So remembering that community-associated infections is different than the HAIs. Community-associated is any infection that a person has came down with outside the hospital facility. HAIs, a lot of them are going to be, or that definition, know that is was acquired in the hospital or institutional setting. They are infections that was not present when that person was admitted, okay? They are definitely more harder to treat because a lot of them are going to be like the MRSA, the VRE. Okay. Again, with HAIs and preventions, we talked about hand washing being the most important factor that we can do as healthcare workers. The difference between an antiseptic and a disinfectant. Antiseptics should not be used on living surfaces, or I apologize, let me backtrack. Disinfectant should not be used on living surfaces. Disinfectants will kill organisms. It's used only on non-living, so like your equipment. And then antiseptics will inhibit the growth, and those are the ones that you can use exclusively for living tissue, okay? Before we do antibiotic therapy, we always get those cultures, right? So wherever the source is, usually blood cultures would come first, and then whatever else is needed. We want to make sure that antibiotics are only given for bacterial infections. And the reason why we need cultures is because that antibiotic can skew the results if you get the cultures after the antibiotic has been initiated. We said that there is gram-positive, gram-negative, and that negative is harder to treat because of the cell wall. The antibiotic therapy as far as the uses, so empiric, definitive, and prophylactic. So empiric, again, is when I will treat this patient before I have that data back as far as like the culture reports or before I get any of the testing done. So empirically, yes, as a trained clinician, I highly suspect that they have a UTI. I don't have the culture report back yet, but I'm going to go ahead and order this antibiotic. Definitive is I have the data that I'm looking for back. I have the report, I have the blood work, I have the culture sensitivity, and this is going to match up. This antibiotic is susceptible to this bacteria that was identified, and I can definitively order the correct antibiotic. Prophylactically, again, is used to prevent an infection because evidence-based has shown that certain things will make somebody more prone to have an infection. So those surgical procedures, and again, folks that have had joint replacements will do a pre-dental, like pre-medication with antibiotics before they have dental work. What am I looking for therapeutic and subtherapeutic responses? So again, thinking about what did you see when your patient came into that hospital? So again, if they came in with pneumonia, you know, what would I anticipate finding with a patient in pneumonia? Is it that dyspnea, cough, crackles in the lungs, coughing up discolored sputum, having high WBC, fatigue? So when they start on that antibiotic, am I seeing a therapeutic response? So you want to take everything that you know that patient presented with or that you know about that medical condition, and I hope to see the opposite. That would tell me that they're having a therapeutic response. Am I seeing that WBC trending down? Am I seeing that patient's fever coming down if they were febrile? Are they starting to feel better? Are they starting to have more energy? You know, is their cough becoming less? Is the color of the sputum starting to not be as discolored? Or is the O2 sac coming up? Things like that, okay? You can also be very cognizant about any hypersensitivity reactions. So that, again, is not just a side effect. These are those reactions gone bad that we don't want to see. And again, those are things like you would see with itching, wheezing, the rash, the angioedema, so swelling, anything like that, swelling of the tongue, wheezing. And if they were getting their antibiotic through the IV, what would be the first thing that would be warranted? It is that you are going to stop that IV infusion immediately and contact a provider. One of the things that does come from antibiotic therapy is C. diff, and C. diff is highly contagious. Some of the signs from C. diff is a temperature, watery diarrhea. There's no form at all. A lot of times they can have abdominal cramps because, again, when that peristalsis is really kind of ramped up with that C. diff. Okay, we talked that patients should always be considered contagious, and you as the nurse can do isolation prevention precautions until it is ruled out. Talked a little bit more about the food-drug interactions. We talked about resistance and those super infections, which are going to be more so like, vaginal yeast infections, the thrush. So we know that antibiotics not only kill bad bacteria, but it throws off the good bacteria as well. And so that's why when that flora kind of gets off in certain systems, like in the vaginal or in the oral, then you can see that candida build up and you can have symptoms from that. When you are having antibiotics that are ordered, you absolutely have to check for that allergy. And remember, we said it's not just going, are you allergic to penicillin? Okay, it is, I note here that you have a penicillin allergy, or you say, are you allergic to something? And they tell you, okay, what happened when you took that medication? Okay, and really be very specific about it. We talked about culture and sensitivity. So the sensitivity is going back to saying on the report that bacteria is susceptible to this antibiotic or it's resistant to this antibiotic. And you as a nurse, you're really making sure that you're looking at those reports, because if the patient is on an antibiotic that's resistant, then it's not going to do any good, okay? Okay. We talked about just some of the concepts when it comes to antibiotic therapy, of how we are going to monitor drugs as far as with the patient's blood levels. We talked about these peak and troughs. And so that's going to show me whether the patient is getting the right amount of antibiotic, or if their body is not handling it well and they're kind of getting too toxic with it, or if they're subtherapeutic. We talked about that you can have synergistic effects, or when using synergistic, where the using two antibiotics together is better than one. And an example of that was with the sulfonamides. The post-antibiotic effect, again, is that period of suppression of that bacteria once the antibiotic is stopped. So I gave the example of like a Z-Pak. MDRO, so those multi-drug resistant organisms like your MRSA, your VRE, your ESBLs, and again, those a lot of times can be ones that can affect higher risk populations, as far as think of crowded areas, so the long-term nursing care facilities or in the hospital. And these drugs are, bacteria are very resistant to a lot of the good antibiotics, and so they can be harder to treat. And again, these are contagious type of bacteria. Looking at the drug classes for the antibiotics, so starting with the aminoglycosides, these are just very potent antibiotics, and you're going to see them more parenteral. The only oral one for the aminoglycoside is your neomycin, and we said neomycin is good to treat C. diff, and it's also good to be given prior to surgical procedures. We said, so again, aminoglycosides are poorly absorbed through the GI tract. That's why we're basically giving them through the IV. Okay, and then prophylactic use. The aminoglycosides, again, with those serious toxicities, they can be nephrotoxic or ototoxic. So nephrotoxic, I'm looking for that kidney damage. I'm monitoring that BUN and that creatinine. For the ototoxicity, if my patient complains of that tinnitus or the dizziness or hearing loss, you need to think that, and you know they're on this aminoglycoside, you would want to hold that infusion, not give that medication, and contact the healthcare provider. With cephalosporins, so again, just that you have those different generations, and the more they were developed, so again, that first generation only covered a small amount, second covered more, third covered more, even more, and so forth. So that's just meaning the generations. They are structurally and pharmacologically related to penicillin. So they're in that very related kind of like distant cousin, if you will. And if I know I have a patient who has a true penicillin allergy, we need to make sure that we do check with the healthcare provider before administering that cephalosporin to make sure or to clarify, because if they really did have that true penicillin allergy, a lot of times the provider may not want that cephalosporin. However, some providers may go back and go, you know what, I really do feel like it's okay. And then as long as you document that, but we just in that mind, they are related, and we have to be very cautious if they have a penicillin allergy before we give it. Okay, that's probably, so like I said, you don't have to go through and know all the drug names. It's really just those special caveats that we talk about to keep in mind. Okay. We talked about with MRSA is the drug of choice for MRSA is vancomycin. Okay. Some adverse effects with your cephalosporins, looks like it's slide 33 potentially. Again, and you can see that mild diarrhea, abdominal cramps, itching. Okay. The next group was the quinolones. Quinolones or fluoroquinolones, and we said these have great oral absorption, so a lot of these are your oral route. But these we do not give with antacids because the absorption can be reduced, so you're not going to get as effective use out of these quinolones if you take it with an antacid. A couple of examples for the quinolones was Cipro and Levaquin, and we said with the Cipro, we do know that one of the main black box warnings was that tendonitis or a tendon rupture. Okay. And we also said when we keep bioterrorism in check in mind that anthrax is also treated with Cipro. Looking at adverse effects with the quinolones, so we're going over whether it is headache, dizziness, GI upsets, and we talked about cardiac, that being a concern. Okay, now we're on the penicillins, and we said that penicillins are great and widely used because they do not kill other cells in the body. Very good antibiotic, been around for a really long time. I said you can have some natural penicillin, so you will see sometimes them labeled as penicillin G, penicillin V, penicillin K, and they can have added derivatives of sodium and potassium in them, so I just know that I am watching patients' electrolytes and so forth. Okay. Just talking again in general for patients who have allergic reactions is if they are on, whether again it's IV, I can turn the infusion off immediately if it's PO and they have a reaction. You need to contact the healthcare provider no matter what if anybody has a reaction. So some of the things, and again, is keeping in mind that it's not always just you're going to see this big obvious whopping reaction. It can be as simple as your patient starts to feel more restless. They feel more anxious. They just are like fidgeting more. And you're like, oh, they weren't doing this, you know, and sometimes they'll just say, I don't know what's wrong. I just don't feel right. And so you really can link it back to going, okay, you know what? They just had this antibiotic, so there's a potential reaction that they're having. So probably across the board, antibiotics are notorious for causing GI upset, nausea, right, loose stools, things like that. One of the things with penicillin, though, is there are definitely some interactions. So we talked about with NSAIDs that they can get a rash. With oral contraceptives, it does make the contraceptive less effective, and we're teaching our patient about secondary birth control measures. And with the warfarin, because it is a blood thinner, it can increase the anticoagulation effect of that warfarin. We talked about Bactrim, and again, that's one of those examples of like a combined antibiotic. It's very widely used, again, for those UTIs. Very good for it. We have let's say just, okay. With Stephen Johnson's, it's that really bad rash. There's no specific treatment for it. Again, it can come from a variety of different medications, not just antibiotics. So the next group I'll go to is your tetracyclines. And your tetracyclines, there was a few special things about those, is that they should not be taken with dairy products, antacids, or iron because it can reduce the absorbency and the effectiveness of a tetracycline. Because it can cause tooth discoloration, it's contraindicated in kids under 8. Also contraindicated in pregnant and or if that woman is lactating. Okay. And we said what happens is that the medication will bind to the calcium that's on the teeth, and that's what causes that discoloration in the teeth. One of the things that we do encourage with antibiotic use is a good amount of water. It will help to decrease the nausea, and if we can again keep that nausea in check, it will help that patient not to that kind of anorexic feeling where they don't want to eat because they don't feel good. Okay. One of the things too with the tetracyclines that we talked about some other potential effects when it came to patient education was, like I said, you can get that maculopapular rash and that photosensitivity, which is that response to light. So thinking of that patient education of telling them, you know what, you need to avoid prolonged direct sunlight, or you can wear a long sleeve, attire or a hat to shade, and avoiding those tanning beds because it doesn't always have to be just natural sunlight. It can be that artificial light as well that can give them some potential harmful reactions. Okay. We said that tetracyclines are a lot of times are used for the STIs or STDs, right? Also used for Lyme disease. When you're thinking of your nursing process, again, it's just thinking, what is our first step? It's that assessment. So I'm looking to make sure, they have allergies? I'm looking at their labs prior, that kidney, liver, any cardiac issues, any immunocompromised issue, any contraindications that would warrant them not to be on that antibiotic use, right? And making sure we have those cultures. we tell with education to tell people to make sure they take their antibiotics as prescribed, and even if you're feeling better, do not stop them until that whole length of treatment is done, because they are prescribed for that amount of time for a reason. Okay, and then we also try to tell usually women like what to look for in case of a yeast infection. Just as far as safety checks, because again, that sounded like look-alike drugs, so making sure you go through those 6 rights. And knowing again, a lot of water is very good to decrease nausea, also help with absorption. And then again, especially if they have a UTI, that 2,000, 3,000 milliliters to help flush out that bacteria in the urinary tract. With penicillins, one of the things is we're just again monitoring that patient after taking that penicillin for at least 30 minutes. We encourage water, not juices, for the penicillin, because acidic fluids can not make the drug work as well. Okay. Okay. And other than that, guys, I think that should be good if you remember those main caveats about just the antibiotic classifications. All right, have a great week.